I would like to thank Professor Kash and his colleague and his team for the invitation. So today I will talk about the management of pancreatic fluid collections. I know the topic is very complex, so I will try to cover it within 20 minutes. So this is my objectives. So I will talk about the classifications mainly, and mainly is about the complex collections, time for interventions when you have to interfere, and management of the collections, multimodal, or you have to consider multi-gate. So, and mainly I will talk about world of necrosis and necrosectomy, because this is the debate and the mortality is very high. Type of stent, and on the end I will end by the giving an evidence of how to manage the disconnected duct syndrome. This is the published guidelines. So the guidelines is very clear for American endoscopy and also the European endoscopy, and also more AGA clinical practice update. They consider some of the management steps, and you have to follow it and you have to review it. And they are differentiated between the pseudocyst and world of necrosis. This is very clear Atlanta classification. As you see, we have the interstitial or edematous pancreatitis, and also we have the necrotizing pancreatitis, and two types of the pancreatitis, and also we have the durations more or less than 4 weeks. So you have to know the outcome of those collections as you have to follow your patients. So was the follow-up of those, the edematous pancreatitis, is most of the fluid will be resolved, 20% they will be ended by pseudocyst. On the other hand, as you see, the necrotizing pancreatitis, most of the acute necrotic collection, they will be ended by world of necrosis. So you need to have to concern about the necrotizing pancreatitis. And at the same time, you have to consider also the extension of the complex collections, either bilaterally or unilaterally, paracolonic gutters. So they're very important to manage. Maybe you consider another modality with endoscopy as percutaneous. Now, what we have to evaluate our patient, usually imaging very important. So CT scan usually done and ultrasound done, but MRCP and MRI, it's the modality of the choice or preferable before you consider drainage for a lot of reasons. One of them, you give you a lot of evaluation about the content of your collections. Number two, it can tell about disconnected duct syndrome if you use the S-secret in MRCP, and also the etiology, it can tell about the stone if there's an CBD stone, and pseudoaneurysm. If you have a pseudoaneurysm, they recommend to treat or to manage the pseudoaneurysm first, and then you can drain your patient. So MRI, MRCP is very preferable before you consider any kind of drainage. As you see, this is CT scan, and also another end by the MR or MRCP. As you see, is MRI is clear, tell us more necrosis compared to the CT scan. EUS also is proven that the guideline, this is ESG guideline, that the EUS is the modality of choice over the conventional any drainage, either percutaneous or the endoscopy, for the safety and also for the real-time imaging. And for, as you see here in this next imaging, you can see you can measure the distance, and also you can see the vessels. You can measure the collections as easy to drain. And the same times also to give you some important about the content and the type of collections. As you see, this is most likely more than 50% of the necrotizing pancreatitis. Maybe you consider one of the lamps. Management is very important to consider the management of why you have to manage your patient based on the goal. So your goal to remove the necrosis, to control the infections, and also to have a clear plan about world of necrosis management with the multidisciplinary or multi-specialty team. The indication usually very important. You can interfere if you have symptoms or if you have complications, symptoms including pain or weight loss, anorexia, complications, either infections, superficial infections, or vascular thrombosis, or maybe you have some time clearly GI obstruction or biliary obstructions. Type of stent, as you see here, is a lot of debates, and it will show in some of the evidence in the next slide. We have to drain the first an index procedure, and then you consider necrosectomy, and then follow up of your patient, either plastic or metallic. So the duration is very important. So we have adapted the durations of the less or more than 4 weeks from the old surgical literature, because they have to have walled or mature wall, then you can drain your patient without any complications. But this one of the studies showed that in sick patient, multi-organ failure, they have clearly that you can drain your patient less than 4 weeks with less complication and also less hospital stay. But we have to stick in our rule. More than 4 weeks is a rule still apply for our clinical practice. Now, As you see, this is the interventions. You have a percutaneous and you have endoscopy and you have minimally invasive surgery. So the endoscopy is preferable for most of the literature and evidence. Now, what we have to consider, open necrosectomy is almost an out for high mortality, more than 60%. So we have to apply the step-up approach for our patient, either surgical or endoscopy. Then we have to have at least clear non-invasive procedure. We start by endoscopic transluminal drainage and then followed by necrosectomy. Then if you are needed to do anything further, patient not improving, you consider percutaneous catheter, and then you can do necrosectomy, or you do a video assessed retroperitoneal debridement. This is one of clear evidence comparing the endoscopy and surgical for pseudocysts. So the debate of the pseudocysts is almost gone. So the endoscopy is better, and also either you can use plastic or metallic. As you see, the recurrence here with endoscopic group is very less, and also the success rate is similar, complications similar, the intervention is similar, but the short length of a stay and cost and less invasive and no recurrence. So the for pseudocyst is endoscopy, either a plastic or metallic. Now, if you compare this Banter trial, comparing the step-up approach compared to the open necrosectomy or surgical, clearly state that trial of 88 patients with all the necrosis, the step-up approach is better, less complication, major complication, death, and also the secondary outcome of other complications is less. So now they consider step-up approach of surgical. And there are a lot of debate about endoscopic and surgical, but this is clearly very two trials stated that one of them is European, and second one is American, state that most of they comparing the endoscopic step-up approach to surgical step-up approach, that the endoscopy is preferable and better and less complication, less fistula formation, and short hospital stay, and also better quality of life. Percutaneous alone is not enough. You can consider it if you have only a patient you cannot approach by endoscopy or far away from GI. As you see, this is a pelvic, is our patient cleared in the pelvic collection, so we use the percutaneous. If you need to do more, you can access this catheter and you can do a necrosectomy percutaneously and to treat your patient. But alone is not enough. The success rate is very low comparing to a lot of studies that stated that 55%, and also the complications and pancreatic fistula and morbidity is very high, up to 30%. Now, endoscopic drainage, so we have to consider the best modality, and then you have a plastic with multiple steps and multiple complications, and you have a metallic is only one step and less complication. This is one of the steps, and you can use for your patients. You have to puncture, and once you puncture, you have to follow by cystotome. After you follow the by cystotome, then you have to consider dilatation using balloon dilatations, different sizes. Then you're placing the first plastic stent. At the end, you have to place another plastic stent, so it will be very challenging. If you compare to the metallic, this is the lamps, as you see here, is inserted and then easy to be done and to deploy. Then once you have to have a clear inside the cyst, you can deploy the other flange in the stomach, and easily to be done within short duration. And this is another lamp. This is hot spaxis, also the same principle. You can puncture, and then once you puncture the cyst, it's easy to have the stent inside the cyst. Then once you have a clear advancement of the stent, you can deploy it over US guided, as you see, longer, and then you have to pull back and you have to snag at the end of your wall, against the wall. Eventually, it will be drained in the stomach. So this type of the lamps, to dilate or not, this depends on your practice, and or you leave it alone after 3 days. Then you put the lamps with coaxial plastic stent to prevent complications and bleeding, or also migrations, as can be done either with fluoroscopy or without fluoroscopy. Now, what we have to have our practice now, plastic stent over metallic stent, is one old published paper. It was published 2013. I think it was stated that there is no difference between both. No superiority for luminopulsing stent, but this, clinically, the cost is very high with the lamps, and the easy lamp to be replaced compared to the plastic stent. But we have another systemic review and meta-analysis from Mayo Clinic. As you see, they prefer the metallic stent for many reasons, toward that less occlusion, less perforations, but the migration is very high. So we have a lot of debate of using the metallic stent, but the guidelines for world of necrosis nowadays, they prefer the metallic for doing a more necrosectomy and you preventing more complications. Different type of of lamps. We're using the 15 millimeter, but this is clearly stated that one of the study and 105 patients using the 20 millimeter, and they have to consider the new size for the human positive stent, and reported that 100% success rate without any problem, and the clinical success rate around also 94%. And they are decreasing in the need of necrosectomy, but the other safety and efficacy and adverse effect compared to the standard 15 millimeters are almost the same. Now, at this another study also, the number of necrosectomy is less with the higher diameter 20 millimeter comparing to 15 millimeter, but the clinical success rate in clinic and also technical and adverse effects are almost the same. Now, using the novel 15 millimeters long or length. Usually we have 10 millimeter. If you have a collections almost away from our wall, the wall from luminal wall, it's difficult to be reached by 10 millimeters stent. So they have a novel stent 15 millimeters. So it has clearly stated that is the clinical success is almost the higher, with also technical success and adverse effects almost the same. So we can have almost using the 10 millimeter and 15 millimeter stent is both is almost equal. Now, different stents can work. So this is one of the also international multi-center retrospective trial comparing the different types of luminal stent, and they are almost the same, but they have biphalange metallic stent. They have dysfunction is more, and occlusion is more, and also the migration is higher, and the need of also necrosectomy is almost higher with the biphalange metallic stent. So we can use what you have, but luminal stent usually very easy to be done and very safely. This is one of the clinical guideline and update or expert review to 2020. They have stated that clearly lamps appear to be very superior to plastic stent in managing patient with wall of necrosis. This is the last, this was published abstract, the one of the trial comparing the luminal stent and plastic stent in the DW 2022. As you see here, there's no different, and they have only the different of the study, the procedure time, and also the length of hospital staying, and also less than 1 week is very significant between the two groups. But in the same time, they have outcomes clear and a short outcome and a long outcome, almost they are similar, but still in their recommendation, they recommend the lamps to be inserted for those patients with wall of necrosis. Nutrition, very important to consider either nasogastric tube or nasogenous tube, or maybe PEG tube if you manage your patient. But if you have to evaluate your patient, if you can tolerate your oral nutrition first by NG tube, and then if not, you consider nasogenal. If not, then you think about the PEG tube. Necrosectomy is very important to have at least one of the crucial steps for your patient. You have to go inside either after 72 hours or maybe in a week after your index procedure, because the outcome of those patients of removing the necrosis is very important. As you see, we're using a lot of devices or ERCP devices to remove the necrosis. At the end, we have to make sure about the cleaning the cavity, and once you clean the cavity, it's easy to place another plastic stent to decrease the recurrence or the intervention of the disconnect duct syndrome. As you see, sometimes it will be completely blocked, and you can remove the huge necrosis from the cavity. Using the hydrogen peroxide or not is very helpful, and the success rate is very high with the hydrogen peroxide, around 93% compared to 78%, without any complications or additional complication compared to the standard necrosectomy. This is what our patient, we have to inject over the necrosis. Don't inject over the clean cavity, because sometimes you can hit an artery or burn the artery, as you see, and a lot of bubble can happen, and then you can use any device to remove the necrosis will help you and decrease also need for necrosectomy. Now we have a new device for those, we call it Endorouter. You can go inside and you can remove the necrosis with the good, safe, and without any complications. Step-up approach of necrosectomy. This is from India almost. They use the 205 patients, and they step-up approach for their patient. They first the index procedure, and then they repeat the procedure to remove any blockage or delogging the stent or they irrigate, and then their study they publish that the success rate is very high, up to 96%, and the need of direct necrosectomy is very low compared to the other paper, is almost less than 9%. There are also a lot of predictor to predict your patient if you have fold of necrosis. If you have a patient with very sick Apache 2, if they have a necrosis more than 50%, and also if they have a bilateral paracolonical gutter extension, those patients they have to have bad outcomes. So you have to consider a lot of way to treat your patient with either multi-gate, or you have to do a lot of necrosectomy. Once you make sure the cavity is very clear, and then you can easily remove the stent without any problem. Lastly, I will talk about disconnect duct syndrome. Very important. It's very hard to be happened with the necrosis. It's almost around 38%. They need a lot of recurrence, re-interventions, and they have to place a plastic stent. A lot of the study that showed that you have to consider exchange the metallic with the plastic stent. As you see, this is one of the study clearly that stated that they have a two group of the patient. First, you have to assess the integrity of the duct. If they have intact, very rarely they have to have a recurrence. If not intact, is disrupted already, no, they have to evaluate the patient, and then if the necrosis happen, they have to put lamps. Then they divide two patients to exchange by plastic or without plastic. As you see, when they change with the plastic stent, the recurrence is very low, 1.4, compared to those patients without any plastic, the recurrence almost at 25%. Another study is published this year from Hyderabad also. There's very good study. The recurrence usually it happens not in the first 3 months. It will happen almost after 6 months. As you see, the recurrence in the 3 months are almost equal between the two groups. Now, this is a group with the stent. This without any exchange the stent. This is where they remove the metallic and they put the plastic. This one, they remove the metallic and they don't put the plastic. You see the first 3 months, the recurrence is the same, but the 6 months, they start to be higher. And then after 12 months, the recurrence is very high. So they recommend to have a plastic stent after you remove the metallic stent. As you see, this is one our patient. Once you have a clear cavity, then we place a plastic stent after removing the metallic. So, and then I will end about 2 things. This is a good guideline to follow your patient. Once you have a wall of necrosis, you have to have a clear transluminal. If you not have a transluminal, you have to consider percutaneous drainage, and then you have to use a percutaneous necrosectomy. If you have a clear transluminal, then you consider lamps. Then you have to follow your patient if you need to do a necrosectomy or not, based on a clinical scenario or the follow-up of your patient. This Orlando protocol, very important to give you a clear, validated protocol. If you have a pseudocyst, there is no debate about using plastic or metallic. It's almost the same. If you have necrotic collections, then you have to consider multiple or single. If you have a multiple, you have one lamp. If multiple collection, you consider multiple transluminal success. If disconnected, then you have to consider placing a plastic stent. If you have paracolonic extension, you consider to be percutaneous drainage with endoscopic. This will have a high success rate and with less complication. So in summary, and sorry to take longer, this is summarizing the conclusions. Those patients, very difficult to manage, so we have to consider multidisciplinary and multi-specialty team-based management. MRI, MRCP, very important to be done before any drainage. Then for
subject. سؤال الحاجة بقى في حالة أنا قابلتها، فعايز أعرف الجايد لاينز هنا إيه في ال word of pancreatic necrosis. The best is metal stent and the best is lamps. When you apply the lamp, patients improving very nicely regarding clinical and lab data. حضرتك هنا بقى بتعمل ايه؟ هل لو العيان اتحسن خلاص يبقى كده you completed the job وتعمل فولو اب، ولا حتى لو العيان اتحسن regarding clinical and lab بتفضل انك بعد 3-4 ايام تعمل نيكروزيكتومي عشان تجارد against او to prevent blockage of the stent بعد 3-4 ايام لما تبتدي النيكروتيك اريا؟ يعني بتعمل فولو اب ومانج according لللاب والكلينيكال سيتنج، ولا كده بتعمل نيكروزيكتومي حتى لو العيان اتحسن؟ دي نقطة كروشيال وما قدرتش الاقي لها اجابة واضحة في الليترشر. يا ريت حضرتك يعني توضح لنا الحتة دي اكتر.
Prof. Hussein, first, thank you for the invitation. And still we are learning from you because you're one of the pioneers in the US. This question is one of the important questions to be asked for our clinical management. World of necrosis usually heterogeneous. So we have a lot of disease, different disease, either big collections, sometimes would have a lot of necrosis, or maybe sometimes it's very easy to drain. What's the guideline and the statement practice or the expert people, what they recommend? A lot of things to be done for this patient. Number one, a clinical assessment is very good. If the patient is improving after 3 days, I will not be rushed to have a necrosectomy after 3 days or 5 days. But I have to follow this patient by imaging to see is it progressing, removing the necrosis or not, to go inside or not. This is number one. Number two, from before you are inserting the metallic stents or the lamps, you can tell the patient is having a lot of necrosis or not. If more than 50% of the collections is the necrosis, those people, they need a necrosectomy, either after 72 hours or maybe they need after a week or some. So it's the percentage of the collections and a sickness patient or patient very sick. And also if they have a long bara. So we have to consider the clinical improvement of your patients. If they are improving, then 72 hours for those patients, they are not improving. So if they are not improving, then I have to go after 72 hours. If they are improving, I will do the imaging after 1 week. And most of the recommended imaging, I'm doing the CT scan. If CT scan tell me the collections is improving more than 25% or 35% or 50% improving from index procedure, I will keep following the patient. If there is nothing improved, or maybe the less than 25% or 35%, then I will have to do the endoscopy to do the necrosectomy. Number three, if the patient is very sick from the beginning, very huge collection, bara, colonic extensions, and they have multiple collection, then I have to consider to remove the necrosis to help the patient if they have a febrile or CRP is very high or not respond to antibiotics. The one of the important to consider removing the plastic metallic stent within duration 4 weeks. That's why you have to finish some of the necrosectomy within 4 weeks if needed, and then better to be removed. You will not keep the lamps longer, 4 or 6 and 8 weeks. Despite that, some of the patients we keep them longer without any complication.